So I wanted to start us off today with a little bit of a look back. I think the concept of COVID in healthcare has been absolutely beaten to a pulp by all forms of media. So I wanted to try and focus, not so much on what happened in 2021 and 2020, but the fact that hospitals were pushed to the brink and in all manner of clinical and financial. And so there was a recent Kaufman Hall report, and it looks like 2022 actually started out worse than 2021 started. Kevin, my first question is, do you think a rebound is coming? And if so, what should revenue cycle teams be focusing on to prepare for that rebound?
Sure thing, Jeff. And hopefully everyone can hear me. I have a little bit of internet issues here today. So if I freeze up, hopefully it's not like in the middle of a sneeze or anything like that. And I keep coming through. But yeah, I mean, to give you kind of like a state of the union, and I wish I could just sum it up and say the state of the union is good or it's strong and make this an easy presidential address. But the reality is we are still very muddled right now. So we have spent the last 2 years with one dominant thing in our minds. And I think we're all tired of talking about it, which is COVID. And we've watched the COVID spikes, happen, and they typically have happened right in the winter months at October, November, December, January timeframe. And it's almost like a little bit like a heartbeat, if you will. So we get squeezed really tightly when we're experiencing peaks. The first peak was, as we know, the Delta wave. The second peak was the Omicron wave. And when that happens, the normal playbook kind of goes out the window. You're fighting desperately for staff because a lot of the staff can't come in. They're sick or on observation status. Your hospitals are inundated with, and I'm going to use this word, I hope it's interpreted right, with the wrong kind of patient. You're built to do surgical stuff. You're built to do hips and knees and hearts, and yet you have a whole lot of medical coming through the door. That's real high intensity, high staffing needs. And so your numbers get hurt, right? You're seeing lots of volume, but it's the quote unquote wrong kind of volume, and your expenses are going through the roof during those squeeze points when it happens. So we did start this year, 2022, if you just use the calendar year, not your fiscal years, because those are all over the place. But January was terrible. The numbers are coming in. February was going to be equally bad, and March is not going to be awesome either. And it's for the reasons I just said. Your hospital is full of COVID. You've seen the pictures on TV. If you don't work in a hospital, you need sometimes 6 nurses around a patient to flip them, prone them, to intubate them, take care of them. That's a lot of resources to go into it. And the number one expense, other than supplies and everything else being higher because of inflation that we've all experienced, whether it's at the pump or at the grocery store or at your local pharmacy or your hospital pharmacy, is staffing. And staffing is really taking advantage of the hospitals right now in some levels. We have heard prices for agency of $200, $250, even $300 an hour. And it doesn't take, a bond analyst to say $250 an hour. It's a $500,000 FTE walking around the hospital. Whereas before it was a $100,000 FTE. That wasn't built into my prices. That wasn't built into what I'm getting from my payers. This is tough times. So yes, absolutely. January, February, and half of March are going to look terrible. Look like really what they look like almost 2 years to the day when we shut down services. It's going to be that kind of event, except no stimulus funding is going to be here. The question on the line is, so I say muddled, what's next? And I think everybody we talk to thinks, yes, a rebound is coming. We have shown more than once that when we've shut down, the volumes come back. So no one's sitting at home afraid, I can't go to the hospital, I might catch it. The hospital is one of the safest places you can be. It's clean, it's sanitary. You take a greater risk getting on a bus or a subway right now than you do a hospital. So we don't see that happening. And there is volumes that have been slowed down, curtailed, put off that still need to come back at pent up volume. It's not as high as you might think, but it's definitely there. So our best guess of the folks that we talk to each day, Jeff, is that, yeah, we got a horrible first quarter. We're going to book it. We're going to try to ignore it, change the subject quickly, and look forward to the summer months when the volumes rebound and my expenses come down quite a bit and things get back as close as we can to, in big air quotes, back to normal. And that's certainly the hope. The one hesitation you hear in my voice and you hear in everyone's voice is if there's another variant that we don't know about that's going to throw us for a curve. And do we look at the same, squeeze or heartbeat, if you will, come the fall months? And does that change the game yet again? But I certainly will say that we expect a seesaw pick back up. I think issuers that we talk to expect the same thing. And so we're at a low spot at the moment, but we certainly hope things level out and certainly get a little bit better in the summer months, Jeff.
Thanks, Kevin. That's perfect. And so Brian, Kevin mentioned the labor cost that's going up. If you in your consulting role now, if you were to talking to someone like Piedmont with such a large revenue cycle group, what advice would you give them as labor costs are soaring and those margins are squeezed?
So I think from a revenue cycle and a lot of back office administrative perspectives, organizations have taken different tacks. Some are moving to more of an offshore model. You can look at what Baylor Scott and White has done, for example, and offshoring a number of their back office functions to be able to have a massive cost reduction. A lot of that was in the works even prior to COVID, for example, and just trying to figure out how to optimize the skill sets that are needed, because it's really become a national and in some ways a worldwide market for labor at this point. So there's organizations who are taking that approach. There's other organizations who have completely reevaluated their real estate footprint and have been able to reduce significant expenses from that perspective as they've moved people to work from home. I will tell you, I've experienced it, and I know a number of colleagues who worked for years trying to figure out how to get people to be able to work from home. And healthcare organizations at times are a bit slow to respond to that wave. But when COVID hit, people were home within 3 or 4 weeks, right? And the productivity that they've been able to get out of their folks has been just as high. I think the challenge that people are having in that regard is just onboarding and how to help create the culture that's needed in order to really sustain and grow careers as opposed to just having a job. I think those are the two biggest areas where organizations right now are really trying to focus their cost reduction efforts and trying to, again, retain their staff.
Heather, from your perspective, you've spent a lot of time in healthcare IT, and when you hear Brian say things like offshoring and sending people home, what do you hear in there that's either coming or something that people should do?
Similar to what Brian was saying, I've been hearing about outsourcing. I mean, it's been almost a year now, and I was talking with the CFO, and it's not just the revenue cycle. His whole finance department is outsourced. I mean, they're outsourcing everything that they can. And he commented about, he gets a report once a month and he reviews it and goes from there. But from an IT perspective, and I think this is something that, kind of came up when COVID first hit, is trying to make sure that, everything is secure. Right. And now in the environment we currently are in, with the threat of cyber attacks and hacking and all of those things, those are real threats to organizations that they have to think about, making sure that the platforms and the software and the technology they use is compliant, is secure, and also patient friendly. Right. There's this whole perspective of, I do everything on this. I got to have that for the team, for my patients, but at the same time, to what level of risk gets introduced. And so I think we're going to start seeing much more focus from large organizations on cybersecurity, patient engagement, all of those types of platforms to help shore up the business and keep everybody remote.
What's interesting is for majority of my career, revenue was always very predictable. Right? You had seasonality to some extent, and Kevin's nodding. He knows it better than I do. Revenue was very predictable. The senior executives in the organization could almost pinpoint what revenue would be. You knew what your patient throughput would be. You knew what your referral patterns were. And that really began to change in 2016, 2017. And to me, it began, from my perspective, again, I don't have facts to prove it, with just the continuation of outpatient diagnostics and outpatient services. And people just don't want to go to the hospital, right? And it's not that they are scared to go to the hospital necessarily, but they don't want to have to drive. They don't want to have to park. They don't want to have to pay to park. They don't want to have to walk a half mile to the registration site, right? It's cumbersome to some degree, right? So they are trying to find ways to, as from a patient perspective, to make it as easy and convenient on themselves. And as a result, you're seeing a lot of diagnostics as well as outpatient services, whether it be therapy or imaging, et cetera, that have historically been very high margin services for the hospitals, right? Hospital-based rates, those types of things. And so I think hospitals themselves are going to have to really revisit how they're approaching things. Many organizations have gotten into some of the retail space, for example, on the urgent care side. And then you talk to organizations like Go Health, who are out there supporting all of these urgent care centers, because hospitals are saying, we don't know how to run them. We don't know how to operate in a way that is in a retail environment. So instead of trying to take what they could learn from how a retail operating environment works in a revenue center, they are just basically throwing their hands up and saying, hey, someone else come and run this, as opposed to taking those lessons and applying it back to their high fixed cost operations and trying to figure out how to turn those cost centers into revenue centers. And so to me, that'd be the biggest advice that I could give an organization at this point in time, is you really got to leverage every bit of your fixed assets. One of the things that I always joked about is, what if you offered MRIs at 10 o'clock at night for $300? Right? There's no traffic on the roads. People's kids are in bed, right? I would love to be able to go do that. Right?
Yeah, I definitely sleep through my MRI. That'd be great.
Well, and Brian brings up a good point regarding price transparency as well, right? I've had a conversation, multiple conversations, but one sticks out in my mind is, Brian, you were talking, where I had a CFO go, what am I going to do? I offer, I own these clinics that can do an outpatient MRI for much cheaper, but I make the most when they actually come into the facility. And so it's balancing that, right? When we, to the topic of price transparency and how that's going to impact things, is, I think, Brian, your observation is spot on. They've got to get their costs down.
I think the other thing, Jeff, I'll just add real quick, is to really try to figure out where you have opportunities for margin improvement on the revenue side. And some of that we'll get to, obviously, in the conversation, I think, in future questions specifically around the patients. Most organizations are not collecting what they should be or could be collecting from the patients. And I believe that's because we've put the patient in the middle as opposed to putting the patient in the center. And what I mean by that is we put the patient in the middle of trying to figure all this stuff out, whether it's what their copay is, what their deductible is going to be, and it's the insurance company and it's the provider. And instead, we've got to figure out how to get some of the waste out of the system and figure out how to really put the patient in the center of what we're doing. And that's going to require additional collaboration between the providers as well as the insurance companies.